candidate.
Yes, Dr. Vijaya, you are up.
Hello. Hi.
Hey,
Hi.
okay, you're welcome. So you can start timing now. So can you tell me, okay, you can request for control, I guess.
We don't see your screen yet, Rasheedah.
Oh, sorry, I forgot I've
Sorry,
not
yeah.
shared my screen. I'm sorry.
No problem. No problem.
Sorry, let me share now. Can you see my screen now?
Yes.
Okay. So you can request for control.
Okay.
I don't see the option for giving control here. Sabahat?
Vijaya, can you see the option of
Okay, no, okay, I've seen
request?
approve.
Yeah, I gave her. I mean, request.
I've
Okay,
given
I'm starting that.
it. Do you have control now?
Vijaya?
Let
Yes,
me see.
you do.
Yes,
Yes, okay.
I have.
Okay, that's fine. Okay, so you can go through these images and can you tell me what study this is, please?
Okay, so I'm provided with the selected images of the neck vessel Doppler, and the first image provided is left common carotid, and in the same image I can see left vertebral artery as well, more posteriorly. And so looking at the direction of the flow, the vertebral artery is showing a reverse flow. I would like to confirm it with the spectrum also. And so I'll be looking at rest of the images as well.
Go through all the images, you're free.
Okay. So yes, now the spectrum is also provided, and it shows that the vertebral artery is showing a reversal of flow. Okay, again the same one. Yeah, left common carotid is showing the flow in one direction and vertebral in the opposite direction. So yes, I would like to, and at the same time, the right vertebral artery is showing normal flow, antegrade flow towards the brain. And I would like to look at the clinical data of the patient, because there is reversal of flow in the left vertebral artery. I'll be suspecting subclavian Steele syndrome in this patient. And here the proximal subclavian artery is likely to be occluded, and the flow to the limb is provided by the vertebral artery. So there is shunting of intracranial flow to the upper limb via this vertebral artery. So I would like to confirm clinically. I'll ask for any exaggeration of symptoms like syncopal attack, etc.
Yeah,
on
presenter with syncope.
exertion. Okay, on exertion. So the findings shall be conveyed on emergency basis to the referring clinician, and yeah, CT angiogram is arranged.
Okay. Okay, that's fine. So this study, do you know in what situations is this study usually done? Can you give me a few indications for this study?
Okay. Whenever we are suspecting an occlusion to the carotid system or vertebral system, or as in this case, when we are suspecting subclavian Steele, then yes, and again, when there is a suspicion of dissection.
Okay, that's fine. Okay. Tell me about this, please. Patient presented with shortness of breath.
I'm provided with a frontal chest radiograph of an adult presenting with shortness of breath. And in the first look, there is a scoliosis with convexity of dorsal scoliosis with convexity to the right side. So apart from that, looking at the lung parenchyma, there are some prominent reticular shadows in bilateral lower zones and some prominent reticular opacities are seen, more prominent on the right hilum, right parahilar region. So again, I don't see any
What,
other
what
lung.
what do you think is going on here?
Yes, with the prominent reticular shadows, predominantly in the lower zones and right parahilar location. I'll be thinking about interstitial lung diseases. And because it is asymmetrical, I'll be thinking about lymphangitis as well. And
Don't have any history of cancer.
there is okay. There is no in the history of cancer. So I'll ask for the occupational history also, and would like to compare with any previous chest radiographs if available.
There's previous, and there's no occupational history that is relevant.
Okay. So yes, I'll be thinking about interstitial lung diseases, and I'll suggest HRCT test for this patient for further evaluation, as this is the first presentation for the patient. Okay.
Control.
Okay. So yeah, I think this is a single axial image.
Not a single. It's not a
Oh.
single. You have control.
Okay. So I'm provided with the axial slices of CT thorax lung window. I think it's overshooting. Let me see. Okay, so I can see the ground glass opacities and interstitial thickening, predominantly involving the lower lobes. Okay, it is involving the upper lobes as well, with some sparing of left apical lung, and this is typical crazy paving pattern. So the differentials I'll be thinking about here include pulmonary alveolar proteinosis. Then again, other possibilities I'll be thinking of in view of present pandemic situation is COVID pneumonitis, but this is less less typical for COVID pneumonia. And again, looking at the clinical data, I'll discuss with the referring clinician and will suggest bronchoalveolar lavage for
What
this.
clinical data would you want to know?
Clinical data, yes, provided with the data of breathlessness. So again, I'll be asking for the test for COVID, including COVID antigen or whether RT-PCR is
Patient does
done.
not have COVID. Patient does not have COVID. So
Okay,
is there
okay.
another thing that you think may help you in the history that you would like to know?
Okay, so in addition to that, yes, whether there is increased expectoration or mucoid sputum production, if it is there or not,
That
that
help?
may
What would
help.
that suggest? Would that help? Would that help you? What would you think if you know there's increased expectoration?
If there is increased expectoration, that is a finding that we expect in pulmonary alveolar proteinosis.
Okay. It's not very specific, is it?
No, it's not specific.
Okay.
So
okay. I want to show you something. Just hold on. What is this?
okay, small lung cyst.
Does that help you in any way?
I'm not sure. Okay, maybe I'll be thinking about the differentials of cystic lung diseases also. So in the presence of diffuse lung involvement and lung cysts, lymphoid interstitial pneumonia.
Okay, let's move on. Let's move
Okay.
on. All right, let's move on.
Okay.
Go ahead, please.
Okay. So I'm provided with a frontal chest radiograph of a newborn. There is opacified left hemithorax and endotracheal tube in situ, and it is well below the level of carina. I think it's in the right main bronchus. So the NG tube is in normal position. So the finding should be conveyed to the referring clinician on emergency basis, and the suggestion should be to withdraw the endotracheal tube and reposition it. So
Is there any other thing in this chest? Is this right lung normal?
okay, it is appearing a bit granular. So so the possibilities, yeah, on a surfactant deficiency, then other it can even
Somebody
be.
is drawing on the screen. I don't know. Hafsa Fatima.
I'm now going to name and shame. Hafsa Fatma, there is annotation.
No, I could actually see the name. So
yes. So please, nobody should disturb the session in between. Okay. If you're on your mobile, do not touch your screen because annotations come even when you touch your mobile.
Okay. Sorry about that, Vijaya.
Sorry, I'm sorry.
No problem.
So the right lung is, what do you think about the right lung?
Yeah, the right lung field is showing some granular opacities. So this could be some neonatal pneumonia, or
Is
because
this child or a preterm child?
yes, it's a preterm child because I'm not seeing the humeral proximal humeral epiphysis on either side. So the
Dr. Nadia, do not draw. Go ahead, sorry. Okay. It's the removal is not working with me. I don't know why the eraser is not working with me.
Okay. Please go ahead.
Thank you.
okay, so the possibilities I'll be thinking of surfactant deficiency. Then because the patient is intubated also, it is probably for administering surfactant. And other differentials, neonatal pneumonia or meconium aspiration. All these are possibilities.
The time is finished.
Oh, okay. Okay. So well done, Vijaya. You did well. So going back to the very first case, which was the subclavian still, you knew it from the very moment you started, but I think you dragged a bit on it. You could have just wrapped it up very quickly. So it was the subclavian still, and you should do further imaging. You need to get the location of the obstruction for the surgeons or the interventional radiologists that may want to do something about it. So you need to do a CT contrast to assess the subclavian artery. So that was very well done. The second case, I know it's not the best of images, I'm sorry, but you actually picked the findings. You could see the patchy opacities that were in the lower zones as well as in the perihilar region. So my little trick for chest like this is once you see perihilar opacities or, opacities of this sort, I have 4 differentials and it has worked very well. And those differentials would include, there are 4 Ps. We have alveolar proteinosis, we have pulmonary edema, we have PCP, and pulmonary hemorrhage. You will not go wrong with this 4 in most cases. And definitely you need to do further imaging, which you finally mentioned. And that usually helps to clarify your differentials. And yes, I know the cyst was very small, but it was like the key to the answer. And the history I was expecting, because you never mentioned PCP in your differentials anyways, but you could have asked if this patient was immunocompromised. That would have also helped. And it's classically perihilar distribution. Yes, alveolar proteinosis is the same 4 Ps will still come in this CT, but the cyst would, support PCP more. So PCP was the answer to this reading. And the last one, you also did it very well. I would advise that we all start with the tubes. When we see any chest with tubes before we start going to the abnormality, but you still did the right thing. You still noticed it was low lying, and yes, the right thing to do is to immediately call the clinician for them to withdraw this and, so that this can get reaerated. But the right lung itself is also not normal. I thought you would have picked the fact that this is a preterm from the beginning of your introduction, that this is a chest radiograph of a preterm neonate, and that is the clue to that, that this is RDS. So very well done. Thank you very much.
Thank you,
Thank you.
Rasheedah, for the cases. And thank you, Vijaya. Mamuna, you are next. Yes. Mamuna, you have unmuted.
Yes.
Yes, okay.
Hello, Memuna.
Hello.
Hey. Is it Memuna? Hello?
Yes.
Okay. Yes.
Okay, so,
yes, yes.
So this is your first case.
Okay, this is frontal projection.
Patient presented with shortness of breath.
Okay. Okay, this is, can you repeat the history? I can't hear you.
Shortness of breath.
Shortness of breath, okay. Okay, this is frontal projection chest radiograph of a female patient. See that.
Mamuna, we are losing your voice.
Can you hear me now?
Yes, just stay. Yeah, this is better.
Okay. Okay, okay. This is frontal projection chest radiograph of a female patient. Bilateral lung fields grossly appear normal to me, and the aortic knuckle is on the left side. The cardiac shadow is normal. The costophrenic angles are normal. It's a bit obscured on the left side, probably due to the overlying breast shadows. There's no evidence of pneumothorax. Bilateral hyla appear normal to me. Since the patient has presented with breathlessness, is there any previous imaging available? Can you hear me, Rasheedah?
There's no previous imaging.
No previous imaging. So,
history you may want to ask them.
Sorry?
Is there anything in the history that you think you want to know?
Yeah, is it acute onset of shortness of breath?
No.
No. The ribs are normal to me.
Okay.
Bilateral breast shadows can be clearly visualized.
Okay.
The trachea is central.
Okay.
So if the patient has presented with shortness of breath, so I'll suggest a CT scan to further take my case.
Okay. So you can't think of any possible differentials even before you go to the CT?
The left apical region appears a bit hyperlucent as
Where? Sorry?
the left apex appears a bit hyperlucent as
So what would you be thinking in that?
it could be, this could be due to any bullous, or it can be due to decreased vascularity in McLeod syndrome. So since the patient has presented with shortness of breath, so I'll suggest a CT scan. These are...
You can ask for control.
Mamuna, go to your, you can see a bar, view options.
Yeah.
From there, the second one, request remote control.
I'm sorry, Rasheedah, can you do it for me?
Let me try. I hope I can. So I click on remote control. Okay, you are Maimuna Murad, right?
Yeah. Yes.
So I think I've given you control.
Okay.
Just click once on your screen, Mamuna, and then you should be able, on your screen
Okay.
first, yes, and see if you can now, yeah.
She's in control.
These are multiple images of a CT scan chest of the same patient, in which I can see that the left lung appears smaller in volume as compared to the right one. And it also appears a bit hyperlucent. I can see some dilated bronchi in both upper and lower lobes, and the hilum is significantly smaller in size. So my diagnosis will be McLeod syndrome, and I'll inform the referring clinician, and the patient should be referred to the chest physician for further management.
Okay, can you release the control?
Okay. Okay, I'm not using it. Okay. This is a frontal projection radiograph of the right shoulder, and in which the glenohumeral articulation is well preserved. The joint space is well preserved. The acromioclavicular joint is normal. However, I can see that there is erosion of the medial end of clavicle. Along with this, I can see that there is a shaped lesion in the right lung, which has significantly spiculated margins. So the rest of the bones are visualized in this part of the radiograph appears normal to me. So, summing up my findings of an irregular shaped spiculated lesion in the right lung with erosion of the medial end of the clavicle. The erosion of the medial end of the clavicle is irregular with it appears aggressive to me, the appearance of the medial end of the clavicle. So these could be due to the lung metastasis, or primarily it can be a rib lesion with a metastasis to the lung. So first of all, I'll suggest a CT, a chest X-ray of the same patient to look for the size of the lesion, and furthermore, the patient needs workup for malignancy and also metastasis protocol like CT scan, chest, and abdomen.
We couldn't hear you, Rasheedah.
Yes, you can scroll.
Okay.
Have control, I guess.
Namuna, you can scroll just like the previous one.
But
Yeah, the control will still be with
Control,
you.
yeah, the one in control. I'm not touching this. I'm not touching the mouse. Hello.
The screen has become smaller on my screen. Can you make it big?
It is big for us. Yeah, it's fine now.
Yeah.
It is okay for us. Just go to the arrows and then we can scroll.
Okay.
Yeah.
Okay, I'm really sorry.
No problem. No worries.
Okay. Okay. These are MR images of a patient. I'll start from the midbrain. Okay. The brain stem appears normal. The cerebellum is normal. These are axial T2 images of a patient. The fourth ventricle, the midbrain, appear normal to me. The lateral ventricles are normal. On this slice, I can see that there are isodens subependymal lesions in bilateral lateral ventricles in the body.
The ventricle is normal.
Sorry?
Normal.
This is normal.
Yes.
Okay. Okay. So I'll scroll again to look for the chiral pattern, which is normal. The thalamus, the globus pallidus, the basal ganglia appears normal to me with no evidence of any abnormal signal intensity. Sylvian fissures are normal. The midbrain is normal. Can I have the history of the patient? Is there any complaints?
This is a 30-year-old female that presented with headache.
With headache, okay. Okay, I'm a bit suspicious about visualizing some part of cerebellar tonsils, which I can see in the foramen magnum.
It's normal.
It's normal. Okay.
So you don't see any abnormality in the brain?
No.
So where else would you look for? Where else would you look at?
In the bones or in the paranasal sinuses. Look in the orbits. I'll scroll back again to look at these areas. I'll look at the mastoid air cells, or the supracochlear chain appears normal to me. The pterygoids.
So look, concentrate on the bones.
On the bones. The right frontal bone appears a bit expanded as compared to the left one.
Okay. So what do you think?
Sorry, just to let you know that time is up. You can go ahead with the case.
That's fine. Okay. So go back to where you pointed to and stay there.
Okay.
And tell me more about it.
Yes. So the right frontal and parietal bone are expanded, and the space is significantly expanded. However, the overlying the cortex is intact. So in a female patient with bone expansion, I'll be suspicious about Paget's disease first.
She's 30 years old.
Sorry?
She's 30.
30. Okay. So it can be an intraosseous lesion like meningioma, or does the patient has any other history? No. Like any blood dysplasias?
Just headache.
Headache. So it can be an intraosseous lesion. To look for bones, I'll suggest a CT scan to further narrow my differential. Can I have the bone window? Okay, so this is the bone window of the same patient, in which I can see that there is significant widening of the diploic space in the right frontal region, and the inner cortex is a bit disrupted near the right bit. However, the overlying, the outer cortex is intact. You can see some lucency also. The lesion has a wide zone of transition. So it looks like an aggressive lesion. And in a 30-year-old female, I'll be concerned regarding any metastasis from breast or bronchus.
Okay, that's fine. So actually, you've done very well. Yeah. This is not an aggressive lesion. It's not aggressive. I don't know why you think it is, but it's very well contained. It has a narrow zone of transition, and you can see that it has this brown glass appearance. So what do you think?
Fibrous dysplasia.
This is a case of fibrous dysplasia.
Okay.
Dr. Rasheedah, your voice becomes muffled sometimes.
Oh, okay, sorry. So if you have an MR that the abnormalities in the bone, you need to ask for a CT.
Okay.
That's the only way you can cone down your differentials, because they can have very absurd appearances at times, and you may not be able to tell what is actually going on.
Okay.
And the way it's just like the region it's involving, the fact that it's a 30-year-old, it's not, there's no destruction of the cortices. So one wouldn't think of an aggressive lesion first. You think of something benign. Okay. So the previous one, you did this very well. However, I don't know why you would want to do a chest X-ray again. It's obvious that there is a destruction here. There's a mass here. You should go straight for a staging CT. And I was actually trying to tell you some history in the beginning, but I guess you did not hear me. This patient came from the GP. So I wanted to see how you would manage this patient that came from the GP. So since it's a GP, if it's a GP patient, then you want to request for the CT abdomen and pelvis yourself. because if you send this back to the GP, it can take a while. So you want to request for this, and so that the patient can be called in immediately for assessment. And you also want to send this patient to the long MDT, because this patient needs to be discussed. Right?
Okay.
Okay. So you don't need to do a chest X-ray again. Just go straight into a CT. But at least you picked all the findings very well. So being a shoulder is just a distraction. This was the main problem. And the first one, you finally got it. So there is this hyperlucency on the right. There is also reduction in the vascular markings on the left, and reduction in the vascular markings, and it was a case of macloids. Very well done. Thank you.
Thank you. Thank you very much.
Thank you.
Thank you, Mamoona. Rasheedah, I'll go next.
Okay. Okay, it's still loading, so you should only look at the axials. That's all you have. The axial is all you have access to.
Okay.
Have you asked my request for control?
Yes, I will. Okay, so I have the axial and the bone windows, or only this?
Start with this, please.
Okay. Okay, maybe it's loading on my side, so it's going to take a while.
Okay, it's done.
Okay. So these are axial images of CT brain in a patient with no clinical history provided at the moment. I'm scrolling caudocranially. I'm taking some time to have a look at the posterior fossa, at the ventricles, at the brain parenchyma, at the surrounding soft tissues. So in the first look, the first finding I can appreciate is that there is a soft tissue density in the midline in the frontal region. And there is mucosal thickening in the frontal sinuses as well. I have suspicion that there might be some involvement or erosion in the adjacent bones as well, but in my usual practice, I would see it in the bone windows. As far as the brain parenchyma is concerned, I have not been able to detect any brain parenchymal lesion. There is mucosal thickening in the right maxillary sinus as well. So within the impression I have from these, apologies, my screen gets stuck, maybe some internet issues on my side. I would also like to add that there is ethmoid sinusitis as well, and I do not see any soft tissues in the intraorbital component. So in summary, with the findings I have mentioned, this seems to be a case of sinusitis with involvement of the soft tissue component as well. I would be thinking about a Potts-Buffet tumor and would look at the bone windows as well to see the extent of bone involvement. Ideally, I would go to either with contrast-enhanced MRI or contrast-enhanced CT after discussion with the clinician.
Why would you want to do contrast-enhanced MR or CT?
To see the extent of involvement of these soft tissues, as well as if there is any subtle involvement of the brain as well, which I have missed in a plain CT.
Okay. So what are the possible complications you're expecting in this case in the brain?
Okay, in the brain, I'm expecting the complication of epidural empyema. I'm expecting the involvement of the adjacent cerebral hemispheres. For example, in this case, the frontal bones could be involved with intraparenchymal abscess. In case of ethmoid sinusitis, I would be fearful of subperiosteal abscess in the orbits. Any extension into the mastoids can even lead to complication of venous sinus thrombosis. So
Tell me the
these,
natural history of this condition.
sorry.
Can you tell me the natural history of this condition?
The patient would have the symptoms, I believe flu-like symptoms. However, the soft tissue swelling would appear for the patient, which would be more concerning, and for his referral to the clinician.
Okay, so what's your next?
Okay, so I have been provided with the frontal abdominal X-ray of a skeletally mature patient, which demonstrates a large soft tissue density, which seems to be arising from the pelvis and going up towards the upper abdomen and displacing the bowel loops cranially and peripherally. I do not see any abnormal bowel dilatation. I can still see air in the rectum. Within the constraints of conventional X-ray, I do not see any free air. As this lesion, as the soft tissue density lesion is arising from the pelvis and going up, I would ask if this patient is a female and would be concerned regarding an ovarian lesion. I would also keep a very large fibroid in my differentials as well. And I would advise an ultrasound pelvis as the next step in this patient.
What if this patient is male?
If this patient is male, I would be thinking of because this is intraperitoneal in location, maybe a large, very unlikely, but a very large distended urinary bladder or a tumor arising from the urinary bladder.
What if it is not arising from the pelvis?
Okay, then it could be a large mesenteric cyst.
What would you do next?
Sorry?
What would you do next?
I would do a CT abdomen in that case, contrast enhanced CT abdomen. Okay, so I've been provided with the axial images of CT abdomen with oral positive as well as IV contrast. I can see that there is a low density, well-defined lesion in the mesentery with a surrounding a rim of wall calcification. I can see the bowel loops being displaced. I'm trying to ascertain the origin of this lesion. I believe this is not arising from the bowel loops. In fact, the epicenter of this cyst is mesentery. So I would keep mesenteric cyst as the prime differential and inform the clinician, because this patient is having pressure symptoms, to have a surgical management of this patient.
What would you suggest? What would you recommend?
I would one thing I would recommend is, and because it's very close to the anterior abdominal wall, an interventional radiologist can be involved to have an what we call the ultrasound guided aspiration. That would also.
This.
Sorry.
Would you be happy to aspirate this?
By aspiration, I mean just for the sake of cytology, the surgery would have to go in for the definite management.
So this is a patient that has cancer of the prostate. What do you think?
Okay, so this is the nuclear scan in a patient of prostate cancer. I have the whole body images in anterior and posterior views. I'm looking at the whole of the skeleton to see any the areas of uptake. I can see it at the shoulder joints. I can see it at in the cervical spine, medial end of clavicle, and most likely at the left, at both SI joint, more marked on the left. But I believe that I would ask the age of the patient, and I would be thinking about a degenerative arthropathy at at these sites, and I do not see any focal intense uptake, which would make me suspicious for a metastatic lesion secondary to prostate cancer.
So what do you think is going on here?
I believe these are degenerative changes. For further evaluation, I would do an X-ray pelvis to see the SI joints and to be sure that these are only sacroiliitis and not a metastatic process involved in the sacrum.
So you think it's a sacroiliitis?
I believe so, because it's on both the sides, more marked on the right, but still I would go for an X-ray pelvis to be sure that what I'm seeing is only degenerative process.
Is this also part of the sacroiliitis?
No, this is the anterior aspect of the left ilium. So this is basically the bone involved. So no, I retract my previous statement. So the left iliac bone is suspicious for a metastatic deposit, and I would do either an X-ray or a CT bone windows to ascertain the osseous nature of this pelvis.
I think this is metastasis, right?
Yeah.
What do you think now?
Yes, so I can see that that when I compare the right and the left iliac bones, the left iliac bone is definitely demonstrates a permeative mottled appearance, and hence with a history of prostate cancer, I would be suspicious for metastatic deposit involving the left iliac bone. And an interventional radiologist should be called in for a biopsy.
Next case.
Okay, so this is the frontal radiograph of a pelvis in a skeletally mature patient. In my first impression, I feel that the bone density of the visualized bones is altered, with increased density noted at both the femoral heads, with sclerosis, subchondral and subchondral lucencies, and there is a sort of deformity and flattening of the femoral head bilaterally. I'm looking for any focal osseous lucent or lytic lesion. I believe that this is a process of avascular necrosis involving both the femoral heads. I'm trying to find the reason for this avascular necrosis in this adult patient. I also believe that there is if I'm not mistaken, if I can use my arrow, there seems to be a subtle lucency, a linear lucency involving the right inferior pubic rami, which might indicate a fracture line. I would be interested in knowing if this patient is a patient of sickle cell disease, or the vertebral bodies do not appear H-shaped. I do not see any ankylosis of the interspinous processes. The patient, I would also certain if the patient has any lymphoproliferative disease like lymphoma or leukemia. In short, what I can see that there is bilateral avascular necrosis of the femoral head. I would discuss with the clinician and try to find out the reason for this avascular necrosis. Otherwise, this would be labeled as an idiopathic AVN and would be referred to orthopedics for the management.
So you've only mentioned just two possible causes here. Said
yes,
looking for ankylosing spondylitis. What else?
Actually, I do not see any surgical staples in the pelvis, which
So
would make me
just give me three more possible causes of this. It does not have to be on this radiograph.
Okay, it can be due to in renal transplant cases, in immunosuppressive therapy, if the patient is on immunosuppressive therapy, and the patient is taking steroids for some asthma or any allergic diseases affecting the patient.
Okay, I believe this is your last case, right?
Yeah, my time is up, yes.
So yes, this is a case of bilateral AVN. The cause is not showing on this radiograph. So
Okay.
it doesn't have to. It's just for you to, like you mentioned, I'm looking for this. So it could be sickle cell. I can't find any features of that. I can't find any features of renal transplant. This patient could be a chronic alcoholic person.
Right. Yeah.
You have chronic pancreatitis. So you just mention as many as you can. Just keep talking and try to move on. Okay,
Right.
so it was actually an MR, but you never talked about doing any for the evaluation.
Yes, you're right.
So that was bilateral AVN actually.
Yeah.
This one, this is it was a distraction. The history is a distraction actually. This is not a case of cancer. It's not a case of metastasis, sorry. It's a case of budgets. So
Okay.
when you're thinking, when someone has, when you're thinking of metastasis, it shouldn't be sort of focal and this diffuse. You
Yeah.
expect it to be maybe multifocal or, and this is a very common site for Paget's. So you need to be thinking of that as well. And you
Right.
should always compare the findings on a nuclear study with X-ray
Yeah.
or CT, just to be able to better evaluate what you're seeing. So the CT was actually the giveaway, but I don't know. You got distracted by the.
Yeah, you're absolutely right.
So it's actually diffusely involving the bone. It's mildly expansile. It's coarse. It's mildly thickened. It's not really dry per se, but at least the medullary cavity we can clearly see
Yes.
the difference. So this is actually Paget's.
Right.
And so the previous one, the X-ray is not the same patient with the CT. So
Understood.
yes, you did this. You did the X-ray very well, and you also did this very well. But I also expected you to actively look for any relation of this cyst with the pancreas to
Right.
be sure that it is not a pancreatic pseudocyst. So
Right.
even yes, it's clearly mesenteric, but you didn't mention trying to be sure that it's clear of the pancreas and rule out other differentials. And yes, you should be able to. There's no worrying feature in the cyst, so you shouldn't be afraid to do an ultrasound and possibly drain it. Not just for cytology, really. You can
Okay.
yes, it can be drained. It doesn't have any worrying features. I don't see
Yeah.
any septations, and those are the things you should mention. You don't see any septations. You don't see any
Solid element.
tissue. Yes, any soft tissue.
Yeah.
Nodular, soft tissue masses within this lesion. So
Yes.
you did it very well. And then the first case, which was the Potts Puffy, yes, you did it well. You said all the right things really. You do a contrast enhanced study or you do an MR because you want to look for any subtle intracranial involvement, such as, there could be meningitis, there could be empyemas, so you want to look out for that. And the natural history is that, it starts like a simple sinusitis that would now get super added infection with an aggressive organism that would now get involved, that will now involve the bone. You now have osteomyelitis. It will now break through the bone and go through the soft tissue or go into the brain. So that's the natural history. So it starts that way and then it ends up being really, like a drastic event and all. So yeah, that's it. So thank you very much.
Thank you very much, Dr. Rasheedah. Excellent cases. Thank you. Next is Nuran. Are you with us?
Yes, I'm here.
Yeah, go ahead.
Hi. Hi, Rasheedah.
My special candidate.
Yes. It's nice to hear you and many again congratulations to you. I'm so proud of you, my dear.
Thank you so much. Okay, so this is your case. So tell me about this.
Well,
Because
You have to take the control from me, I guess. Okay, I'll give it to you. Sorry.
Okay, that's fine.
Yeah, fine.
Is there any specific history in this patient?
Okay, sorry, I'm just giving you control, Nuran.
Okay.
I'm not giving you any history.
Okay.
So scroll through this. Okay, hold on. I'll scroll through. Don't. Okay. So, yes. So this.
Well,
you'll see images, and then you tell me about it. So this is the first one. There's the second one.
Yes.
It is labeled, so you no problem. So these are the three.
Well, yes, as it is labeled, I'm provided with the axial images or transverse images of the ultrasound images of testis. There is a multiple tubular and cystic lesions in the most probably this is upper part of the testis because the testis is not seen here. So maybe it is this. And in the Valsalva maneuver, there is increased vascularity and engorgement of the vessels here surrounding these cystic lesions. So I think this patient has varicoceles of the testis because it is increasing in size. These vessels are increased in size with maneuver, with Valsalva maneuver, and there are multiple cysts here in the epididymis.
So what's your diagnosis in this case?
Varicoceles of the testis. So maybe the patient is infertile and came to control.
Okay, so apart from infertility, how else, how do these patients normally present?
Yes, they present with pain in the groin, especially when they are standing for a long time. And most probably in patients that it's occupational sometimes, like in traffic policies or in some people who are standing a lot, they have pain in the groins. And when they sit or lie, they get better benefits. So I should discuss it with the referring urologist for further surgical management if possible.
Okay, so if you see this kind of case, so you would just immediately inform the referring clinician. Is there anything you think you can still do in this case before you even?
Well, I will look to the other side if it is unilateral or bilateral, just to be sure if it is on one side, and we'll look to the other vessels. Maybe he has some. I will ultrasound the other vessels, the femoral vessels and the upper extremities, and look to the scrotum if there is effusion, fluid collection, hydrocele in the scrotum, and I will also examine the testis in these patients.
Okay, so the testis is normal, the left side is normal. What else would you like to do?
Okay.
The patient is still on the couch.
If the testis is normal, I will look to the scrotal sac if there is effusion, fluid collection, sorry, to know if he has hydrocele also with the varicoceles.
Anything you would like to do while the patient is still on the couch?
Maybe, I don't know.
You don't want to examine any other part of his body?
To elevate his parts, maybe?
No, examine. Is there any other part of his body you may want to examine while the patient is there with you on the couch in the ultrasound room?
Well, examine his groins maybe for any mass effect here, there, pressing on the vessels maybe.
Okay.
I'm not sure about it. Sorry. Sorry.
That's fine. Okay, so that's your next case.
Okay, I'm provided with a plain X-ray of the pelvis with there is the upper femur, specifically the left one, is the tubulation is disturbed in the femur with the femoral head is also not well seen within the hip joint. I think the hip joint is disturbed. There is loss of the space in the joint, and there is a diffuse sclerosis and some. It could be. Is there a possibility of a trauma in this patient? Maybe he is a neglected case of a trauma, because there is a periosteal reaction and osseous, irregular osseous formation around the hip, both hip joints, specifically the left one, disturbing the femur, the pelvic bony cage.
So what are you?
Soft tissue, yes.
I
think this, yeah. Can I see the other images, the lateral view, for example, if possible?
The lateral, I'm not sure that would really help you, but I'll give you. I'm not sure it's going to help in any
No,
way.
I mean the one which is below it.
You want to see this?
The knee one, yeah, okay. The knee joint is also disturbed. So this patient is, I think he's not using his extremities because there is a lot of flexures and secondary to the flexures, there is bony bridges between the bones. So either it is secondary to a trauma, multi-trauma, or it is a syndrome, maybe a congenital syndrome, but I'm thinking of the syndrome, I can't find it because there is bony bridges fusing.
Okay.
Extremity. Yeah.
You can't remember the differentials of this?
Well, the differential in this case, it could be an infection, maybe a chronic infection with bone formation or post-trauma,
Okay.
or maybe soft tissue formation, like endocrine disturbance like hyperparathyroidism, but there is no loss of bone densities, like renal osteodystrophy.
Okay.
Well, yeah. Okay, I'm provided with an AP view of shoulder X-ray. Looking to the shoulder, bony structures like glenoid process and humeral head appears it's okay. Well, and the clavicle, the medial side of the clavicle looks more dense, as if it is there is more sclerotic lesion in the diffuse sclerosis in the medial end of the clavicle. Keep me think of sclerotic or osteoblastic metastasis. I'm looking to the lung field, the left hemithorax. I can see something remarkable there, no pneumothorax, no hilar mass, the heart outline. It looks normal as much as possible in this view. So my possibility is there is increased sclerotic sclerosis in the medial side of the clavicle, left clavicle. It could be osteoblastic metastasis.
Okay, that's right. So hold on.
Okay.
So you can scroll through.
Okay, thank you. Well, I'm provided with the non-contrast CT.
Are you scrolling?
Well, I'm trying. Yeah, it's coming slowly. With this is contrast enhanced arterial phase of upper abdomen CT. I'm just trying to look to the quickly to the images. Can I show something in the right lobe of the liver? I want to be sure.
Yeah, that's fine.
Can't go.
Use the small arrows below. I think those are safer.
Okay. Okay. Yeah, I think there is some low dense rounded lesion in the periphery of the right lobe. Maybe segment 7 with the surrounded hyperdense density surrounding this lesion. Either it is calcification or contrast. Yeah, it is contrast enhanced. So this is tubular or nodular enhancing lesion peripherally. So I would like to see the delayed images just to sure if it is hemangioma, because hemangioma is it enhances from peripherally to inside.
Okay.
So can I go to any?
No, you're not clicking. This is the only one we're going to talk about. So
Okay.
what to confirm your diagnosis?
Yeah, this is a lesion in the right lobe of the liver. First of all, I'm thinking of hemangioma, but the differential diagnosis could be HCC, hepatocellular carcinoma, but because the liver outline is not cirrhotic, not lobulated, and the liver looks, liver texture looks normal, so I don't think of hepatocellular carcinoma. It could be other lesions like FNH or adenoma, but the patient, is she or he, is she female or no?
No.
Sometimes male. So adenoma is mostly in the female, specifically with the contraceptive, the patient when takes contraceptive pills. And FNH has a scar in it, and there is no scar in this lesion. Fibrolamellar hepatocellular carcinoma also has a scar. This lesion mostly goes or fits, keeps with the hemangioma because it is peripherally enhancing in a nodular pattern. And I think in delayed films, it can go inside and fills in. That's why I would like to also image, to see the previous images, either ultrasound or, if possible, previous CT, to know if this lesion was there before.
Okay, that's fine. Do we still?
We'll have to make this the last case because only 7 seconds left. Thank you.
That's fine. Okay, well done, Ran. You did very well.
Thank you.
This you got it from the start, but you dragged a bit on it. You don't need to be. Just stick to what you're thinking and say what you want to do to confirm your diagnosis. It's nodular, it has a nodular enhancement on the arterial phase, and you expect it to fill in on the portovenous and the delayed phase. So it's, yes, that's what it is. You give a good, you give good differentials, and you also rule them out. So that's fine. So you did it very well.
Thank you.
So the previous one, so this one, you could have asked for history. There's nothing wrong with the medial end of the clavicle. So if I told you that this was a case of trauma, would it help?
Well, I haven't seen any fracture, maybe because of my excitement, but I'm just looking again to the ribs and clavicle. Can you help me in this matter? I haven't.
Yeah, so this is actually a case of pneumothorax. So please look very well before you say there's no pneumothorax. It is not very, it's a bit subtle, but it's there. Can you see it? Can you see the pleural edge?
Oh, now I can see it. Sorry. It's very subtle. Yeah.
So there's no other abnormality here. That's the only abnormality.
Yes.
So it was a pneumothorax.
Yes.
So you could have asked for history, that might have helped, so that you know it's not osteoblastic,
Yeah, thank you.
Yeah. So this one, so yes, you gave good differentials, possible history of trauma. So in case of trauma, you're thinking of myositis ossificans. So this is actually a case of myositis ossificans progressiva. And that's why it's, it looks a bit, aggressive, involving so many parts of the body. And, so it's basically heterotopic ossification, and minor trauma could just result in this kind of excessive callus formation, resulting in deformity.
Okay,
Thank
you.
You're welcome. And this one. So what I wanted you to do was examine the abdomen of this patient. So when you see a unilateral varicocele, you want to look above to see if there is a mass or an obstruction from above. Okay. So you have to look for that. So this actually had a mass in the retroperitoneum, and that mass, there was a CT actually, and the mass is a very vascular mass that had an abnormal vein that was draining into the gonadal vein and rendering it incompetent. So that was what was causing this patient's varicocele. So when you say unilateral varicocele, you want to look for, so you have to start thinking of possible differentials like an abdominal mass, a retroperitoneal mass. You're thinking of maybe a thrombus in the vein, something occluding the vessel, So you have to think of those things, and so you have to go upwards and look for those causes to
Thank
exclude.
you. I never knew this. I just learned it now. Thank you very much.
You're welcome. You're welcome. Okay, so I think that was your first case. So thank you so much.
Thank you.
Thank you so much, Nuran.
Thank you too.
Thank you, Dr. Rasheedah, for such great cases. Dr. Rohit, you are next.
Yeah, can you hear me, ma'am?
Yes.
Hello, Dr. Raid.
Hello, ma'am.
Sorry, Raid. Am I calling you well, please? Okay, let me give you control. I can see your, can you ask for control, please?
Ma'am, can you scroll down for me, ma'am, please, if you can?
What's your name here?
Rohit.
Oh, this one, Rohit, right?
Yeah.
Okay. Okay, so. So this is the only one you have access to. You can scroll through the images.
Okay, okay. So these are, ma'am, can you scroll it for me? I'm not able to scroll it down, please.
Okay, that's fine.
Yeah. So these are the axial non-contrast CT images of the abdomen. And these are the axial non-contrast CT images of the abdomen. First of all, I would like to correlate with the clinical findings. What are the presenting complaints of the patient? And I am suspecting a diffuse circumferential wall thickening of the stomach. And I would like to correlate this with the contrast enhanced images. Although stomach is not optimally distended.
Stomach is normal.
Okay. So I will, okay. So there is some any presenting features of the patient or any clinical complaints, ma'am?
You need to look for something to know what presentation you want to ask for.
Okay.
So I've told you the stomach is normal. Is there any other thing that is, striking to you in this patient? Is there any other abnormality that you can identify?
I can see some sort of fullness in the left kidney, ma'am. So might be that patient has presented with some pain in abdomen or pain on the left side.
The kidneys are normal.
Okay.
Apart from this tiny stone.
Okay, there's some calcification in the left kidney.
But that's not where the problem is. Is there any other thing you can see in this case? A bit odd. Is there anything you can see? Nothing?
I'm not able to spot any abnormality
on this particular slice. What do you think?
There is, yes, ma'am. There is some hypotension lesion in the liver.
No. Those are vessels. It's a non-contrast study.
Yes, ma'am.
Tell me the density of the
there
liver.
Is, yes, the liver appears hypertense.
Okay.
And liver appears hypertense. So if there is, I would like to measure the attenuation value of the liver. And this could be related to any history of any drugs which the patient might be taking for cardiac ailment, or like iodine drug, like heart failure drug.
You can't remember the name.
Amiodarone.
Okay.
Or it could be related to some disease like hemochromatosis, which can attribute to the hypertension of the liver, ma'am.
Okay, if you're thinking amiodarone, is there any other thing you would like to look for in this study to support your thoughts?
Then I would like to look for the visualized lung bases in lung window and the part of the heart, if they are visualized on the scan.
What are you looking for in the lung bases?
Some sort of lung fibrosis,
okay.
Basal lungs.
And if you're thinking hemochromatosis, what would you want to look for else in the study?
Ma'am, then calcification in the pancreas, which I'm not able to see, or I cannot see any altered density in the spleen. So,
Okay. Another part of this patient you want to check on this scan? Pancreas, you've talked about the spleen. And if you see some densities in the pancreas or the spleen, how would that help you? What would that point you towards?
that points towards, ma'am, that that means that the patient is having hemochromatosis manifest as some sort of iron deposition in the pancreas also.
Okay, what type of hemochromatosis is that?
Ma'am, this is congenital or hereditary.
Okay, that's fine. Okay, so you have to scroll through these images. Take your time, scroll through before you start talking.
Okay, ma'am. Not able to scroll through, ma'am. Please, if you can.
Okay,
I'm
that's
so sorry.
so let me just start from the beginning.
Okay. So these are the axial slices, non-contrast of the chest in mediastinal window and abdomen. Yes, I can see that.
If there's any
Can I
way
start?
stop,
Yes,
to stop.
I can see in the pelvis that there is a lesion, which is there is a lesion with the hypodense lesion with calcified rim and central hypodensity. So in my routine in the pelvis, and the central hypodensity seems to be fat. So
You want me to stay here?
yeah, I want to stay in the pelvis, ma'am. Yes, ma'am.
Okay.
Yeah. So there is a calcification in the periphery of the lesion and the central hypodensity, which has the same attenuation as of the subcutaneous fat. So to me, the lesion appears to be dermoid because it has both components of fat and calcification. So most likely this is a dermoid cyst from the right ovary, ma'am.
Okay. So is that all you can see in this scan? I'll give you a little clue. There is an incidental finding in this scan. Can you try to look for it?
Okay. In the chest, I can see that there is a, yes, ma'am.
No, if you want me to stop, just tell me. That's why it's actually better you scroll yourself, so you'll be able to know where you want to look at very well.
Okay, ma'am.
So, okay, let me give you another clue. This is a woman. So where do you think an incidental finding is likely to be? That would be really, that's, can change patient's management.
Okay. So
which area is not usually well looked at when you're looking at chest, abdomen, and pelvis? It's not the focus really.
okay.
Do Do you have an idea?
Uh,
Areas that are not usually looked at very well.
yeah, it might be the breast which are not adequately visualized on CT.
Concentrate on the breast. What do you see anything?
Yeah, there is some nodule in the right breast, ma'am.
Tell me when to stop.
Yes, ma'am. So I can see that there is some nodular lesion in the right breast. So which may be suspicious, or it needs to be correlated with the other modalities like mammography and ultrasound to further evaluate the lesion, ma'am.
Okay. So you want to further evaluate this?
Yes, ma'am.
Okay.
These are the craniocaudal images of the right mammogram, and I can see that in the right breast, the outer quadrant contains an ill-defined lesion. There is no associated skin and subcutaneous tissue thickening, nipples, and so this is suspicion of some lesion in the outer quadrant, ma'am.
Okay. So what do you want to do?
I just want to correlate with the MLO view, ma'am. The lesion is seen in the
इन्होंने बर्तन धोए?
inferior quadrant, ma'am, and it has speculated margins. So it is highly suspicious of some, I think Barrett's 4 or 5 lesion, which needs to be further biopsy by image guided biopsy.
Okay. Do we still have more time?
Pardon, ma'am?
Sabaha, do we have more time? Okay.
We have 1 minute and 15 seconds.
Okay, that's fine. Okay. Another breast for you.
Yeah. So these are the MLO views. MLO views where I can see that there is a
MLO.
Yeah, MLO view of the breast where I can see that there is a round to oval
Okay.
dense lesion.
Which view is this?
MLO, ma'am.
Okay, so this is not MLO. This is CC.
CC view. Okay. So there is a lesion which is seen in the upper outer quadrant. It is well defined dense lesion round to oval. So it appears to be benign, and I would correlate it with the ultrasound to look as if the lesion is benign, cystic or solid. To ascertain the nature of the lesion, to me it appears to be Barrett's 3 lesion, ma'am.
Barrett's what?
Category 3 lesion, ma'am.
What would you do?
I would like to do an ultrasound of the patient to look at whether the lesion is solid or cystic.
So why do you call it Barrett's 3?
The lesion is well defined, round to oval, and it has smooth borders, and there is a thin rim of lucency around the lesion, ma'am.
So what is Barrett's 3? What kind of lesion is Barrett's 3?
The lesions which have which needs to be follow up, or which have a low risk of malignancy, ma'am.
So, but you're describing something that you think it could be a cyst. It's well defined. Would that still be?
Yes, ma'am. Maybe I would first do an ultrasound and then ascertain the nature of the lesion, ma'am.
That's fine. So this is the ultrasound.
Yeah. So this is a
sorry. Let's know the time.
So this is a round to oval lesion, which is more wider than tall, and it is hypoechoic with fine internal echoes, and most likely it is an cystic lesion. I would like to do an aspiration and cytology of the lesion, ma'am.
Okay, well done. Very well done. Good. So yes, this is well, they don't use birads here. They use
Okay.
M for mammogram, M1,
Okay.
M3, and then
Okay.
ultrasound is U1, U2, like that, U4. So 3 is indeterminate. So in this case, probably maybe because of the age, you want to still further evaluate this to be sure that it is not something to be worried about. So maybe on that basis, you may want to say it's 3, but you've described all the features that says that it is likely to be benign. It has a halo around it. It's well defined. So it should be between it should be M2, but fine, it's okay to say I would like to still take a look with ultrasound to confirm my findings of it being benign. So that was a cyst, a breast cyst.
Okay, ma'am.
The previous one, the dermoid was a distraction. The main thing about this was that breast lesion. And you described it as spiculated. It's not spiculated, really. It's quite round, not very well-defined margins though, but on mammogram, it's not spiculated, especially on the MLO. It's quite round.
Okay.
Quite round, but if the halo around it is not complete, so this still makes it suspicious. And then you don't I can't remember exactly what you said after seeing this. You didn't talk about ultrasound at all. So whenever you see a breast lesion, you have to do the triple assessment.
Okay.
So you need to examine. There will be clinical examination. You do the mammo, the ultrasound, and then the biopsy or the fine needle aspiration and all. So those things must be done to come to a conclusion. So you do the ultrasound revealed that it was actually a malignant lesion, which was not very clear on the mammogram. So this is the lesion on ultrasound, very ill-defined lesion, sort of almost wide, taller than wide, and then it's actually ended up being a lobular carcinoma.
Okay.
So the teaching point in this case is it's very easy to have ignored that small lesion in the breast and thinking that the problem, was in the pelvis. And you could also have asked for any history. So there was a history of weight loss. So that may also make you want to look for something malignant in this patient. Okay, so the previous one. So this one is just a hyperdense liver.
Okay.
That's all that is here. And I just wanted you to identify this and then tell me differentials, which you finally mentioned, amiodarone, hemochromatosis. So regarding hemochromatosis, you want to know if it's a primary or a secondary. So when the liver is the only one that is hyperdense, that's the primary. Once the spleen and the pancreas are also involved, then that's the secondary. So other things you want to look out for is you want to check out the bones, because you want to see if this patient maybe has thalassemia, or any hematological disorder that would require him having transfusions, So you want to look for all those things to help tie up your differentials properly. So you want to mention all that. Okay.
Okay, ma'am. Thank you.
I think those are the cases really.
Finished?
Yeah, I think that's it.
No, there are. We did not see the end. Leila, you are up. Maybe you'll get 1 or 2 cases, but it's okay.
So who's next?
Leila.
Okay.
Yes, I'm here.
Yeah, she's here.
Hi, Leila.
How are you, Dr. Rasheedah? Congratulations.
Thank you very much. Okay, so here you are.
Okay. So I'm presented with a frontal radiograph of a neonate. It's a babygram exposing the chest and the abdomen. And first, there are lots of tubings seen, suggesting that this baby is in the NICU. And also, I cannot see the humeral head ossific center, suggesting that this is a preterm baby. By first evaluating the tubes, the ETT is in low position, and this needs urgent attention. The umbilical artery catheter, I think it's in satisfactory position, probably at T11, maybe T2, T10, sorry. The umbilical venous catheter is in very high position. It's reaching to the inferior vena cava and maybe in the, I'm not sure what this pulmonary artery or what. So there's two things here need urgent repositioning of the EDT and the umbilical venous catheter. Otherwise, there is some granular lung fields of the baby, suggesting the RDS. Abdomen, bowel looks look fine. I don't see any sign of necrotizing enterocolitis. There is no portal venous gas. The skeleton looks okay, normal. So in summary, these are the findings that I can see in the and the malpositioned endotracheal tube and umbilical venous catheter, and these should be conveyed urgently to the NICU specialists.
Okay, so this umbilical venous catheter, what do you think is going on here?
I think it's reaching through the inferior vena cava into the through a patent corner well into the left atrium.
Sorry, I didn't get that.
It's passing through the inferior vena cava to the right atrium and then through a patent foramen well into the left atrium.
Fantastic, well done. So you need to have the control for this, Leila, right?
Yes.
Okay, I've given you control, so you have access to only the axial. Check your time to scroll through.
Okay, I'll start from the beginning. Okay, so I'm presented with a CT study of the abdomen axial sections. It's non-enhanced. The first thing that I can see is a fluid collection in the right paranephric space, or right retroperitoneal. It's also in the and extending across the midline to the opposite side. There is hydronephrosis in the right kidney, and I'm tracing the right ureter to see why is it obstructed. Gets a bit lost here, but the fluid collection is reaching down to the pelvis. Okay, so in summary, this is a non-uniform fluid collection in the retroperitoneal space in the right pararenal. I could not see the reason for the right hydronephrosis. My differential for this lesion. First, I'll check the pancreas because pancreas is important. Pancreas looks normal. There is no sign of pancreatitis, so it is not the source for this collection. My differential for this collection, it either could be a pyelonephritis, for example, with a extensive fluid collection, or could be an abscess formation, a hematoma, which could be a spontaneous hematoma since it's related to the psoas muscle, or otherwise, given that the patient is having hydronephrosis, this could be a leak of urinary leak from some injury to the urinary tract system. I would like to continue this study by having a contrast study with the delayed phase to delineate the pelvic cell system and the ureter. First, to see the source of obstruction and to confirm if there is a leak or not.
So, which one would you pick as your top differential?
Urinary leak is my top differential.
Okay. So why would this patient have hydronephrosis? Were you able to find the cause for that?
No, I tried to look for a stone. I couldn't find a stone. So it could be some other. I'm not sure really. If it could be.
This can't be the problem.
Sorry?
You think this can't be the problem?
I didn't get you. I'm sorry.
I said, did you see this?
No, it ran fast.
Okay, that's fine. Okay, that's fine. Let's go. Okay.
Okay. So I'm presented with an MRI study of the cervical spine, sagittal sections. This first sequence is a T2 weighted sequence, and I can see that there is an abnormal long segment T2 hyperintensity in the cervical cord. I'm not sure why the mouse is moving spontaneously. And it's seen almost, one of them is seen over opposite C2, and the others are seen at C4 to six, 7, and T1, from C4 to T1. So this is a very long segment. Basically, it's involving the posterior aspect of the spinal cord rather than central or diffuse. There is no dilatation of the central canal by looking at other parts of the upper cervical cord. Yeah, there is another segment here also in the upper thoracic cord. And again, it is long segment and lying in the posterior aspect of the cord. I would like to check other sequences for the signal intensity in T1 and contrast.
Which sequence?
T1 first.
T1, okay.
Yeah. Okay, so the signal is not well appreciated on T1, suggesting that it is either intense or hypointense. I will look at the contrast. I'm not sure if there is some patch enhancement or this could be an artifact here in the upper thoracic spine. The rest of the affected segments do not show appreciable enhancements. So in summary, I'm dealing with a multi-focal lesions in the spinal cord, in the cervical and thoracic segments, and these are hypointense on T1, hyperintense on T2 with no enhancement. They're basically centered on the posterior aspect of the cord, where the sensory tracts lie. So my primary differential would include vitamin B12 deficiency or other possibility. Multiple sclerosis is less likely since it doesn't take long segments. Transverse neuritis is also another possibility.
So if you're asked to pick a blood test to confirm this diagnosis, what blood test would you do?
B12.
Okay. Can you tell me some causes of B12 deficiency?
Sorry?
Can you tell me a few causes for B12 deficiency?
B12 deficiency usually occurs with abnormalities of the stomach and terminal ileum. For example, bariatric surgeries with the reduction in the size of the stomach, or long-term gastritis, I think.
Okay, so the last case.
Okay. Okay, so I'm presented with a frontal radiograph of the skull, and I can see that there is an abnormally enlarged right orbit with an abnormality in the orbital walls. I think the problem is related to the greater and lesser wings of the right sphenoid bone. So I think that this patient may be having neurofibromatosis, since there is a deficiency in the greater and lesser wings of the right sphenoid bone. In that case, I would like to check the patient himself for the abnormality, and also I don't see any neurofibromas in the soft tissue provided in the image, so I cannot see any neurofibromas in the scalp. This would be another thing that I would like to check with the patient himself.
Okay, what if I tell you that this patient does not have neurofibromatosis?
Mm.
Is there another thing that you can think of? What if I tell you that this patient has breast cancer?
Breast cancer? Okay, then I would be suspicious that the patient could be having some sort of metastatic disease to the skull. In that case, I would like to refer the patient for CT of the brain to see exactly the distribution of the affected bones and if the distribution of the metastatic deposits, if there are.
Okay, well done. I think your time is up. And
Yes, the time is up. Thanks so much.
last case actually. So very well done. You did very well. So this is actually a case of a bare orbit, and they're limited differentials really. The first one you mentioned is the neurofibromatosis, which is correct. Another possible differential is it could be metastasis. So the bone could be destroyed. That is why you don't see the greater wing and the innominate line. I've forgotten the third differential, but I think there are three main differentials for a bare orbit. I've forgotten the third one, but mainly neurofibromatosis and metastasis, and I think maybe isolated sphenoid dysplasia. I think that may not be related to neurofibromatosis. So that was it. So very well done. So we go back to the previous one. Yes, you were right with this. It was subacute degeneration of the cord, and that is due to vitamin B12 deficiency. I thought you were going to ask for the axials, but you didn't feel the need for it. So, but you still got the diagnosis. Very well done, and you gave very good causes for it as well. And then the previous one, yes, your differentials were right. So this could be, but the fact that it is a bit low in density would fit a urinoma rather than hemorrhage.
Yes.
The fact that the patient had some degree of hydronephrosis, though yes, I agree the stone is very small, but that was actually the cause of the problem. So it was an obstructed ureter, which resulted in hydronephrosis and then calyceal rupture. So this was a urinoma. There was no history of trauma in this case, really. So it was just a case of calyceal rupture. And you said the right things. You would do CT contrast with delayed phases to confirm your diagnosis. I just did not show you because you said all the right things. So there was okay. No, this was even post intervention, anyways. But yes, you're right. The post contrast will show the urinoma better with contrast within it. The one before that was yes. So this was malpositioned tubes basically with RDS, and you did it very well. So this one was actually going from the IVC into the right atrium through the patent foramen valley into the left atrium. So that was fantastic, really. Well done. Thank you very much, everybody.
Thank you. Thank you so much, Dr. Rasheedah.
Thank you so much, Dr. Rasheedah. I mean, excellent cases. And I think, how in the simple cases we can make the mistakes and go towards, scoring marks, which would lead to you failing the case, actually. There were very good examples for it. So thank you so much. Amazing cases, and every case had a very, very good teaching points. For the audience, I have put in a link for a feedback form. Yes, the feedback form is for all the participants. So please, if you can fill in the form, that would be really beneficial. Some people are raising hands. Guys, you can put in the chat box whatever your questions are, because we have enabled the chat. There are lots of thank you messages, Dr. Rasheedah. I'm waiting for a question if there is any. Otherwise, you can give the closing remarks, Dr. Rasheedah. Thank you so much for all of this. Thank you, really.
Okay, so everyone, should also be thanking the team group. You guys really, I can't talk about my success without you guys. Thank you so much.